Hello everyone, welcome to Nurse Bestie Explains. Today I am here with another video with 10 more important OBGM midwifery practical nursing VIVA questions. Let's start this video with the first important question, that is PROM, pre-labor rupture of membranes or premature rupture of membranes. It is the breaking of the amniotic sac, that is amniotic sac, or water breaking. In common words it is water breaking before the labor begins. Okay, before the labor starts, the breaking of amniotic sac, which can occur at a term before the labor. At full term it can occur, or preterm also it will occur, usually less than 37 weeks of gestation. It typically presents as a sudden gush or steady leakage of vaginal fluid. It starts as a sudden gush or leakage of the vaginal fluid. It is a spontaneous rupture of membranes before the onset of labor. Preterm premature rupture of membranes is defined as premature rupture of membranes before 37 completed weeks of gestation. Risk factors are increasing friability, decreased tensile strength of the membranes, okay, and infections like bacterial vaginosis, polyhydramnios, that is excessive amniotic fluid, multiple pregnancy, more than one fetus, cervical incompetence, and previous history of premature rupture of membranes. Diagnosis: escape of watery discharge per vaginum, a gush of fluid leakage from the vagina, that is amniotic fluid. Okay. In this condition, prophylactic antibiotics are given to minimize maternal and perinatal risk of infection, and predominant risk for patients with PROM between 32 and 36 weeks is chorioamnionitis, and predominant risk for patients with PROM between 28 and 32 weeks is hyaline membrane disease. Use of corticosteroids is helpful to stimulate surfactant synthesis against respiratory distress syndrome for the babies, which is advised. Next topic is obstructed labor. Definition is: obstructed labor is one where in spite of good uterine contractions, okay, in spite of good uterine contractions, there will be presenting part is arrested due to mechanical obstruction. The presenting part will not descend beyond that because of the mechanical obstruction, that is called as obstructive labor. Causes of this obstruction can be CPD, cephalopelvic disproportion, fetal head too large for the pelvis. Fetal head is very large. Fetal problems like hydrocephalus, swollen head or large baby, macrosomia, abnormal presentation, brow face, that is chin posterior presentation. You can see here brow presentation instead of cephalic, vertex presentation, brow presentation and face presentation. Shoulder, transverse lie or locked twins, twin babies who are locked. Maternal problems like pelvic tumors, narrow pelvis, cervical or vaginal abnormalities are scary. Symptoms or signs for maternal include prolonged active labor, more than 12 hours labor, still there is no progress in labor, strong persistent contractions with no cervical change or fetal descent. So contractions will be very strong, but still no presenting part descent can be observed. Pain, dehydration, anxiety, dazed state or shock. Signs of impending uterine rupture also may take place. Signs will be observed: hard uterus, tender uterus. If the mother pushes some more, the uterus may rupture. Okay, rising retraction ring. Maternal infection, swollen cervix or distended bladder. What is the treatment for the obstructed labor? C-section, cesarean section, most common treatment for a live baby. Vaginal delivery, sometimes you can use a forceps or vacuum, but often not possible. Better to go for the cesarean section. Some fetal interventions. In case of hydrocephalus, CSF can be drained. Surgical options like symphysiotomy, cutting pelvic cartilage in extreme cases only. Post-delivery management of bleeding and infection. Next topic is vasa previa. Vasa previa is a rare life-threatening pregnancy complication where fetal blood vessels from the umbilical cord or placenta cross the cervix unprotected by placental tissue. You can observe in the picture here, usually these are umbilical cords, okay. Umbilical cord surrounded, this vein and arteries are surrounded by the Wharton's jelly, but here those veins, everything is exposed, and before, as the labor starts, before the presenting part, these veins will get stuck, they start advancing, okay. So because of that, what happens? Rupture may take place. These vessels can rupture during labor when the water breaks, leading to rapid severe blood loss. Because of the rupture, what happens? Severe blood loss, high risk for fetal death or stillbirth if not immediately treated. Treatment includes, only treatment is to have a safe delivery by cesarean section. C-section should be planned as early enough to avoid an emergency. When you observe itself, do not wait until the delivery process starts. Better to plan for emergency cesarean section. Usually C-section is recommended at 35 to 36 weeks. If you observe this condition through ultrasonography in early stages, you can plan for a C-section at 35 to 36 weeks provided the mother is normal without any risk. That is vasa previa. Next topic is umbilical cord prolapse. You can see in the picture normal position of umbilical cord. In umbilical cord prolapse, like this umbilical cord is seen before the presenting part. The umbilical cord descends into the birth canal ahead or beside the presenting part of the baby. Before or along with the baby's head, the umbilical part of the umbilical cord starts prolapsing through the birth canal. Types are overt prolapse and occult prolapse. What is overt prolapse? The cord passes through the cervix into the vagina after membranes have ruptured. Once the membranes rupture, umbilical cord starts coming into the prolapsing into the birth canal. Occult prolapse, the cord lies alongside the baby's head. Along with the baby's head, it starts coming out. Or breathe sometimes does not pass through the cervix. Prolapsed umbilical cord assessment you can do by cord visualized protruding through the vagina. In vaginal inspection, cord you can observe the cord, okay, protruding through the vagina. In per vagina examination, cervix, if you examine something squishy, pulsing, you can observe. That indicates umbilical cord. Mom feels something between the legs, something hanging between the legs like this. Nursing interventions are elevate presenting part of the fetus of the prolapse cord. You can insert your fingers, elevate. Keep your hand on the baby's head, lifting it up and call for help. Like this, you can lift the baby's head, call for help. Position, knee to chest position, you can see in the picture. To open the pelvis, Trendelenburg, let gravity shift baby of the cord. Administer oxygen, wrap cord in sterile moist towel. If it is hanging outside to avoid infections, wrap it in sterile moist towel. Never attempt to push the cord back in. Okay, never try to push the cord whichever is prolapsed back into the uterus. Emergency cesarean delivery can be planned. Next question is shoulder dystocia. Okay. It occurs when the anterior fetal shoulder impacts the pubic bone. Anterior shoulder impacts the pubic bone. It gets stuck at the pubic bone and delivery process will be obstructed. It is diagnosed when gentle downward traction fails to develop. Once the head is delivered, you hold the baby's head and gentle downward traction. You can deliver immediately the shoulders. After the shoulders, baby can be pulled outside. But here that gentle downward traction fails to deliver the shoulder, sometimes marked by the turtle sign. Turtle sign you can observe, head retracts back. While often unpredictable, risks include maternal diabetes, fetal macrosomia, large baby, previous shoulder dystocia and obesity. Management includes maneuvers, McRoberts maneuver, suprapubic pressure, internal maneuver, posterior arm delivery and emergency measures like as Zevenelli maneuver, replacing the head or really breaking the clavicle. You can see the maneuvers here to resolve the shoulder dystocia. McRoberts maneuver, flex the legs to the abdomen. Ask the mother to flex the legs towards her abdomen. Suprapubic pressure, okay, pressure above the pubic bone can be applied. Posterior arm delivery, deliver the posterior arm first. Then Wood's corkscrew, okay, rotate baby's shoulder and Rubin's maneuver, okay, adduct shoulder forward, okay. With this maneuver, shoulder dystocia can be relieved. Turtle sign you can see here, like this can be seen from the mother's vagina. Next one is destructive operations, okay. Destructive, the word itself is telling us destructive, something destroying, okay. Destructive operations in obstetrics are a group of embryotomy procedures designed to reduce the size of a dead fetus. If the fetus is dead before the delivery, for facilitating vaginal delivery, these type of procedures are used. Those important procedures are craniotomy, decapitation, evisceration, and fluidotomy. What are they? Craniotomy. Here the fetus is dead. Instead of going for a cesarean, anyhow the fetus is dead, removing the fetus through normal vaginal delivery is the goal. So to remove the fetus, dead fetus, you can conduct craniotomy. Empty the contents of the brain head through craniotomy. Then easily you can deliver the baby. Decapitation. Okay, that is severing the baby's head. Okay, sever the baby's head, separate from the body, and remove part by part. Evisceration is empty the organs of the thoracic and abdominal cavity. Empty the organs, then the size of the baby will be reduced, so baby can be easily delivered. Cleotomy, clavicles you can cut so that the shoulder girdle will be reduced. Shoulder girdle will be reduced so that the baby can be easily passed through the vaginal canal. These are the destructive procedures used in the obstetrics in case of dead fetus, to deliver the dead fetus. Next important topic is breast engorgement. What is breast engorgement? It is a condition in which breast become overfilled with milk, blood, and lymphatic fluid, causing swelling. Because of the overfilling with milk, blood, and fluid, swelling, pain, hardness, and discomfort during the postpartum period, usually 3 to 5 days after delivery. Okay, this can lead to infections also. What are the causes? Delay in initiation of breastfeeding. Immediately afterwards, within 5 to 10 minutes, you have to put the baby to the mother's breast. So initiate the breastfeeding. If there is any delay, it may lead to breast engorgement. Okay. Infrequent or missed feeding. If you miss the feeding, thinking mother is taking rest, sleeping, that can lead to that. And improper latch or positioning. Improper latching and positioning of the baby, sudden weaning, excessive IV fluids during labor can lead to breast engorgement. Symptoms: swollen tender breast, difficulty in breastfeeding, painful breast, and nipple discomfort. How you can prevent this? Breastfeed frequently, on demand. Whenever the baby cries, put to the breast. Ensure proper breastfeeding. Use breast compressions. Avoid skipping feeding. Avoid using bottles in early stages. Express milk if the breast is very hard. Express manually. Wear a supportive bra. And common treatments include the measures, nursing measures: hydration. Ask the mother to hydrate herself. Take rest. Express the milk. Try different positions to feed and latching. Anti-inflammatories can be given. Massage over the breast. Kinesiotaping, tape application can be done on the breast. Ultrasonography, acupuncture, hot bath or shower. Application of cabbage leaves to the breast, engorged breast. Warm, cold compress and herbal compress. These measures will be helpful sometimes to relieve the pain and engorgement. Next question is postpartum blues. Postpartum, after the delivery, okay, or baby blues. It is a common temporary condition. It is a temporary condition affecting up to 85% of new mothers, characterized by mood swings. Mother will face mood swings, anxiety, and tearfulness starting 2 to 3 days after childbirth. It is caused by rapid hormonal shifts and fatigue, typically resolving on its own within 2 weeks. Postpartum blues versus postpartum depression. Okay, while baby blues are normal, most of the mothers will have baby blues, but temporary adaptation period. But postpartum depression, PPD, is a more severe lasting condition. The blues involve mild transient sadness, while PPD involves intense long lasting despair. You can see here postpartum blues. 50 to 85% of mothers in first 2 weeks they will face. Symptoms include irritability, anxiety, fluctuating mood, and increased emotional reactivity. Mild and spontaneous remits, not considered a psychiatric disorder. This is normal for most of the mothers. Whereas PPD is 13% mothers in first period after the delivery, the first year after the delivery, they face this problem. Symptoms: excessive guilt, anxiety, anhedonia, depressed mood, insomnia, suicidal ideation, and fatigue. Moderate to severe symptoms, prolonged course. It's a prolonged course. Another condition is postpartum psychosis. Okay, so this is about postpartum blues. Next question is maternal mortality rate, MMR or ratio. The MMR is expressed in terms of such maternal deaths per 1 lakh live births. How many deaths? Maternal deaths per 1 lakh live births. In most of the developed countries, the MMR varies from 4 to 40 per 1 lakh live births. In the developing countries, it varies from 100 to 700. With India, what is our India's rate? 254 per 1 lakh live births is the maternal mortality ratio. WHO's Sustainable Development Goal is to reduce the global MMR to less than 70 by 2030. The goal is reducing the MMR by 70 by the year 2030. With a maternal mortality ratio of 113, this time India has missed the 2017 National Health Policy target reducing the MMR to 100. Okay, it has failed to reach the target of reducing to 100. Next one is perinatal mortality. Perinatal mortality is defined as the number of fetal deaths. Perinatal, okay, fetal deaths past 22 or 28 completed weeks of pregnancy plus the number of deaths among live born children up to 7 completed days. After the birth also, within completing 7 days after birth, if the baby dies, okay, that also included per 1000 total births. The causes of perinatal mortality are major causes if you see 30%, 35% due to asphyxia and prematurity. Okay. Other causes like congenital anomalies, sepsis, maternal diseases, and unexplained causes. Next one is neonatal deaths. Neonate period we call it as from 0 to 28 days. Any deaths in this within 28 days after birth, okay, death of the infant. Neonatal mortality rate is the number of such deaths per 10,000 live births. Majority of the deaths occur within 48 hours of the birth. The common causes are preterm birth complications and intrapartum. During the delivery, any maternal complications or fetal complications can lead to neonatal deaths, sepsis, pneumonia, diarrhea, tetanus, congenital, and other causes. Next one is perinatal mortality. Perinatal mortality is defined as the number of fetal deaths past 22 or 28 completed weeks. Okay, fetal deaths 22 or 28 completed weeks of pregnancy if the baby dies in the mother's uterus, plus the number of deaths among live born after the birth children up to 7 completed days of life per 1000 total births. This is perinatal mortality. The causes are asphyxia, prematurity, congenital anomaly, sepsis, maternal disease, and unexplained. This we have already seen. Next one is infant mortality rate. Okay, IMR. Infant mortality rate is the number of number of newborns in a specific geographic area in any country, state, or any town, county, etc. dying under 1 year of age divided by the number of resident live births from the same area, town or village, whichever you take. The number of deaths divided by the live births, live children, residents, live births for the same area and multiplied by 1000. This is the infant mortality rate. Calculation, you can see the formula, number of resident infant deaths divided by number of resident live births into 1000. Okay, these are the 10 important questions. Next video will come with some more important questions. Like, comment, share, and subscribe to this channel. Please share and forward these videos to your friends so that everyone will be benefited for the exams. Thanks for watching.